The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, from back pain to paralysis, the case for open disclosure.
Did we miss anything along that journey that might have prevented the progression of the disease?
That's Dr. Paul Lane, the Medical Director Safety, Quality and Innovation at the Prince Charles Hospital in Brisbane. He's a senior intensive care specialist and I'm presenting him with a difficult scenario.
There would be concerns in terms of permanency of harm.
In today's scenario, as Medical Director, you are asked to urgently review the clinical record of a young adult patient who presented to the ED late on a Friday evening with non-specific back pain. They were admitted under orthopaedics for a full workup on Monday morning. Over the next 24 hours, their pain increased, and they developed a fever early Sunday morning. The patient was reviewed by the on-call surgical registrar, who raised the vague possibility that they may have an infection, but did not progress with any further investigations or start any specific treatment. The specialist was not contacted. Later that day, the patient deteriorated significantly, becoming septic and requiring transfer to ICU, where they were diagnosed with an epidural abscess. They now have what appears to be incomplete paraplegia, having lost the function of both legs. The parents are distraught and want to know how this could possibly have happened. I started by asking Paul what key issues a scenario like this raises.
I think for me, the key issue around this case is that managing deterioration space, so that you've got a patient that's been in your hospital for 48 hours and I guess despite observation and care in the orthopaedic ward has progressed to septic shock and having neurological injury. So the concern would be, did we miss anything along that journey that might have prevented the progression of the disease? And I think the second point is obviously that from a family perspective, it's very difficult for them to understand how this could have happened. And so talking with them and trying to allay some of their fears and work with them along the recovery journey for their son. That's probably the two main issues that I would pick out of that.
This scenario raises the whole question of open disclosure. Can you talk us through what open disclosure means? When should it be undertaken? Who might be the person or the team that would make the disclosure?
The way I've practiced open disclosure within the Queensland health context, we tend to have what we call initial clinical disclosure. So obviously something has happened. We think that there may have been some concerns about management of the patient. So an initial clinical disclosure to apologise for what's happened and to reassure the family and the patient that there will be a review. And then obviously as you do that review, more formal open disclosure towards the end of that process, once a formal review has been undertaken, and I guess to the best of the team's knowledge, the facts are there, and indeed hopefully some recommendations can be made depending on what the team find in terms of improving care moving forward. So disclosure for me is a process that starts at the bedside, very much like what's happening in this scenario, all the way through to a completed report where you might be meeting the family for the third or fourth time, but discussing with them now what the report has found and what the implications are for the system and the clinicians involved.
You need to provide a factual explanation, but at this stage, a lot of it's speculation. How much of that speculation would you discuss with the patient and their family?
I think certainly you can offer an apology that this has happened. The parents are obviously distraught and they will require, I guess, a degree of comforting. I think they'd like to know that you're involved as the medical director, and obviously letting them know that you will be looking into the case, and that at this stage it would appear that it would meet the grounds for a clinical incident. There would be concerns in terms of permanency of harm, so you would probably be going down that pathway of a SAC1, whether it be a root cause analysis or a clinical review team. Generally, when I'm involved in scenarios like this, I certainly let the family know my name, my contact details. I would probably visit them fairly regularly and make sure there's clear and open communication with them. And obviously then working with them and the clinical teams to ensure that the man's treatment is optimised moving forward, so that there's no further concerns about delays or anything like that. So becoming involved early on is something that I've done in the past, and just trying to comfort the family at this stage. Obviously, it can be a devastating diagnosis. And I guess the young man has, a septic shock episode with epidural abscesses, so he's still quite unwell in the intensive care unit. So there's a bit of a journey for them just to get him better from that perspective.
The patients in ICU, who would you expect to be involved in that initial clinical open disclosure discussion? Nurses, doctors, yourself?
David, certainly from my perspective, if the ICU or someone, obviously I'll become involved. So someone's reached out to the clinical governance team or to me directly. So of course, very happy to help. Often if the family is quite distraught and causing some management concerns or issues in the intensive care unit, the ICU team will often reach out. There's perhaps a fairly junior surgical registrar involved in the case over the weekend. So I wouldn't like to put them into that sort of situation, certainly now that the family's become heightened. And it may well be that the relevant orthopaedic or neurosurgical consultant might want to be involved in any disclosure, and certainly outlining to the family what the management plan will be in the coming days to weeks. Obviously, the intensivist that's caring for the patient at the moment and the nurse unit manager for the ICU or the nurse at the bedside, they're the sorts of people that I've had involved in cases like this in the past. Obviously, the surgical registrar will be quite distraught. I'm sure they're very upset with what's happened to the patient. So making sure that we are meeting with the family, but also offering support to our colleague and making sure that they're involved.
It can be really challenging when a registrar is distraught. Can we have a look at the difference between apology and admission of liability? All the textbooks say open disclosure is about providing an apology, but shouldn't involve an admission of liability. How do you split the difference?
Yeah, for me, apologising for what something's happened and what someone's experienced or what a family is experiencing has always been a part of my clinical care. I work within Queensland, and certainly the legal framework supports that apology. And I guess the framework from the Commission around open disclosure also supports that apology. Through the disclosure process, you try and put forward the facts as best as you can ascertain them, but we're not in the practice of allaying blame or telling that someone was negligent or whatever. That's a legal framework, not a clinical framework, not an open disclosure framework. So families will often talk about wanting to sue the hospital, for example, and certainly that's their right to take a legal process. My job as an open disclosure clinician is to, let them understand what's happened and what we're doing as a system to improve care moving forward. I've had situations where people want to bring lawyers to open disclosure, and you say, look, that's fine, but it's not a legal process. This is a clinical process. And good lawyers who come along say that to families as well. So that's the way I approach things. David, one of the things that people often ask me when I'm delivering open disclosure training is around recording the open disclosure. Obviously, what I say to families is that some notes will be taken. And generally speaking, I'm very happy to share those notes with the family. In other hospitals where I've worked, we actually record the session and we provide that recording and transcript to the family. And in that way, I guess we have a sense of control about what's recorded and what's then put forward, because obviously these days recordings and so forth can be changed. I like to be on the front foot with being transparent around the conversation that we're having. In terms of providing the report, let's say we've done an RCA. If that report's been done properly and de-identified and not blaming any individual, generally speaking, I would like to provide that report in its entirety to the family. all the information is discoverable anyway through freedom of information and so forth. But having said that, not every health service will do that. But generally speaking, a provision of the executive summary of the review and what we found and the recommendations that have been put in place and an accompanying letter around the open disclosure meeting itself, I think those things can and should be provided to families.
I think that's a really important point, Paul, because at the point of disclosure, there's so much trauma and baggage and overlay that the message may not get through. Having a recording, either a verbal recording or a written record, provides the patient the opportunity to review what the findings were at a later date, but also to share them with interested parties, maybe the in-laws, that are the knowledgeable people and can help interpret and say, no, that's not what they said this. So important to have a reference point that they can come back to.
The other thing too is with technology, certainly I've used Microsoft Teams as a platform so that I might be in front of the patient or a family member, but someone's dialing in from far away to be there as support and ask, their question. So I think there are always going to be some little curveball challenges that comes along, but the technology that we've got available now, I think can improve the open disclosure process as well. I don't think I'd do a Microsoft Teams as my first open disclosure, but I think if you've been around a while, and particularly if you've met this person before, but now they've moved away, they've gone back to their place of work or something like that, then I think, doing a Teams link up is absolutely fine.
The patient's an adult. They're in ICU. They may not be conscious. The parents are the ones that are distraught and have raised the issue with you. There's likely to be a partner involved. Who do you include in the open disclosure discussions?
It really depends on the clinical state of the patient. In most instances, if there's a good family unit around the patient and the patient has a next of kin on their file, then that's quite easy to either consent the patient or with the next of kin present, talking to them about what's happened. I think over time, the patient may wish some further privacy and decide who wants to be involved. But for a young man, I guess in my clinical and medical administration practice who's potentially delirious or unwell, involving the next of kin if they're stated is my normal practice. And for complex families, often social work can help. You get the social worker involved and they can work out who perhaps is the most reasonable person to talk to in a given situation. But ideally, you get consent from the patient if they're awake enough. And if not, I think mum and dad at the bedside as next of kin is quite appropriate. I guess the challenges would be if there's a partner there who doesn't want the mum or dad to know. And I guess you'd have to work through that over time, but an initial apology to the partner and letting them know who you are and how you're going to be involved in the case moving forward would be reasonable.
You move into an investigation and it rapidly formed the opinion that there may have been an element of negligence on the Sunday morning in particular, where the on-call surgical registrar reviewed the patient and didn't appear to take any action. How much of that suspicion do you share with the family?
I think that's a very difficult scenario. What I would do is explain to the family what the facts were. The family may raise concerns about the performance of the registrar. What I would say to the family is that we would have processes that we would enact to manage the performance of that registrar if it's deemed that they didn't act at the correct level for their training and so forth. I would also remind the families that these are doctors under specialist training, and so they're not specialists in their own right. I think it's a difficult scenario. I certainly wouldn't share any further sort of HR or disciplinary or notification matters with the family, but I might let them know that there is a separate process occurring around the performance of the registrar, but I wouldn't go into any specific details. The most likely thing is that the registrar had not seen epidural abscesses before and perhaps didn't have the confidence to ring the consultant and would be horrified with the outcome for the patient. So, yeah, I think you've got to manage these things very carefully. What I've found in investigating these sorts of instances, David, is that often other people were concerned about the patient but didn't escalate their concerns either. And certainly there was always an ability to ring somebody else to get them to come and review the patient or to support the registrar through the decision making. So I think it's a complex matter, but obviously letting the family know, look, there is another process that's occurring, but I can't share with you the details around the registrar.
How much do you involve the family in the investigation? You set up the RCA panel. How much do you involve the family in that investigation process?
For me, my practice is obviously that you're setting up a review and you want to answer their questions. So if they've got specific questions that they want answered out of the review, it's very simply they can document those down and you can pass them on to the team as, these are specific questions from the family. That's my normal practice. I don't involve them more closely than that. The other comment that I would make, David, is in a case like this, if there is a degree of heightened emotions from the family, and I would often involve a senior external expert. So I'd reach out to a colleague in another hospital, for example, because I think with this sort of thing, if you really are concerned about a number of different issues in the performance of your hospital, getting someone external, I think, gives a degree of transparency and validity to the family when you give them the findings of your review.
One of the challenges, and you've already sort of alluded to it, is this tension between dobbing in one of your employees who you may find is negligent and being open and transparent with the family. Where does your loyalty lie and how do you balance that tension?
I think the report and the review findings from an RCA is about systems improvement. So when you set out to do these sorts of things, you're not looking to blame an individual. And so the report should be de-identified and written in a way which addresses those system issues and outlays the facts around the case and when decisions were made. I would always separate that out to individual performance concerns and manage those through a different pathway. We don't know the circumstances of this registrar. We don't know how long they were awake for. We don't know what their call burden has been, what their private life is like. Have they just failed an exam? Are they struggling? We don't know. And so I would work through that and support the registrar through the process. Obviously, they'll have directors of clinical training and surgical colleagues and peers. And so that, I'd wrap that around the registrar if there's concerns around their performance. And then the RCA will deal with the system issues. And generally speaking, even when an individual may have made a potential error, you'll always find system issues that perhaps if the system had just worked a little bit better, the outcome might have been different.
I think it's a particular tension when it's so easy for patients to lodge a concern with AHPRA now. You just go on the website and type it in, and that can add double jeopardy or double trauma to the poor registrar who was doing their best that morning.
Yeah, look, I think my experience of those sorts of processes, though, is that I think even the high-level system managers recognise that our clinicians are human, that mistakes do happen, that people can be sleep deprived. People in an after hours capacity might be managing a large number of patients, receiving phone calls, referrals, other issues. They might be getting called to theatre. And so the importance here is that the registrar is supported, and if there's any deficiencies in knowledge and performance, they're addressed. We can sit back in hindsight and say that the case was quite clear. At the time for that registrar, it was a young man with a bit of fever who's got a bit of back pain. I mean, you're not going to MRI every man who comes into ED with that sort of picture. So it's difficult. Again, assuring OHO and AHPRA that you're working through the issue and that you're supporting the registrar and so forth. Sometimes if you're concerned, you might discuss with the clinician themselves and through their medical indemnity provider whether they should make a voluntary notification. Then you're letting AHPRA know that you're aware that your performance may not have been at the standard that you would expect. And so certainly giving the registrar support and talking to the medical indemnity provider as well would be something that I would recommend that they do.
There's a reasonable chance that the investigation will find that the inaction by the registrar on the morning made no difference to the outcome, that this unfortunate young man had an infection that had been present for some time, and the fact that the registrar didn't follow up with an MRI made no difference to the outcome. The family's likely to find that very hard to believe and conclude that the hospital is involved in a cover-up. How do you work with the family around this difficult piece of communication?
I think for me, It comes back to the start of our conversation, David, in that hopefully as the medical director responsible, I've built a relationship with this family and the patient. So they're aware of what's happened and the review that we've undertaken, that I've had an external expert involved to help guide us with any recommendations or findings, and certainly being transparent with the review document itself and demonstrating to the family that we've done this comprehensive review and we've got a great timeline. We've identified and interviewed all the right people, and that the findings itself will be escalated through the hospital executive so that, there is a degree of transparency in the process. I think that people will not always necessarily agree with what you've found or what you've done, but obviously you can only try and convince them through the validity of the process and what you've done to try and understand what happened and what you can do to change the situation. Most families hope that this doesn't happen again to somebody else. That's part of, I think, the healing process for them. And so if there are any recommendations coming forward around, for example, the recognition and management of sepsis or any other improved neurological observations, whether there's something that the nursing staff might have been able to do at the bedside to better detect neurological deterioration, those sorts of things, I think they're important to discuss with the family. I think if you're meeting this family for the first time in a boardroom with a report and you've never visited their son and you've never spoken to them before and there's no relationship present and the hospital's been very standoffish, maybe they've gone to the media, then the chances of them believing your report are probably very, very low.
I think that's absolutely critical, is getting on the front foot. If you wait until the patient or their family lodge the complaint and express their concerns before you start telling them what happened, you really are making it extremely difficult. I'd like to step back, Paul, and just ask an interesting question as far as a medical administrator goes, and that is, how do you know if open disclosure is working effectively in your hospital?
Yeah, that's a really good question. In the places where I've worked and I've seen it done well, it's an operational arm of clinical governance. It's an active process. You're identifying the cases that are coming through patient safety, particularly the SAC1s and the other high-risk incidences. You're often assigning the trained individuals in your organisation to those cases and working through it with the relevant nursing and complaint staff. So you're taking a sort of spreadsheet approach to it. You've got people coming through your organisation that are listening in on open disclosure and who are undertaking some of the training. If you're engaging with people early, then they've got no reason to go to the media to try and get answers. If you can give them the answers and they've got your phone number or your email address, then they're not really going to go somewhere else if you're actually letting them know what's happening and updating them. So I think if you're maintaining that sort of confidence in your brand, and I think if you've got a good program happening in your hospital that's got oversight from executive, a number of people trained in open disclosure, people coming through the ranks who are undertaking the training, and I think you're probably doing a pretty good job. You're not going to get a high five at the end of an open disclosure. I mean, some of these things are absolutely bloody sad and terrible. But generally, people will say, thank you for this process. Thank you for apologising. Thank you for telling me what happened. And thank you for being transparent enough to give me, what recommendations have been put in place. And yes, it's a terrible outcome for our loved one, but, we recognise it's not always easy for you, and thank you for the process. So I guess that's the wrap of the whole thing.
Comes back to the heart of clinical governance. It's all about culture rather than compliance. And if you've got a culture of openness, frankness, and engagement of the patient, then you're running a high-quality organisation. If it's just about compliance, we did it because we had to, we ticked the box, it's a sad state.
Really, from a clinical perspective, it's around rebuilding the trust with the healthcare system. And if you're in a one-hospital town, this is going to be your hospital for the next few years, then you've got to actually, that open disclosure process is not only important for the patient, but their family, their relatives, because that's the hospital that they go to. I think people accept that things don't always go right, but they expect that an apology should follow, and that there's that expression of regret, and that you listen to their concerns and you come up with hopefully some changes which will improve the system. Prof. Sanford Allen used to say, Paul, open disclosure is an act of kindness. And I think that whenever I'm teaching open disclosure now, that comes out pretty early on. The patient or family in front of you's had a really terrible time. And so being compassionate and kind is a good place to start.
That was Dr. Paul Lane, the Medical Director Safety, Quality and Innovation at the Prince Charles Hospital in Brisbane. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.